one up outside. So this is an ongoing seminar series, the first of which is on bone and joint, and there are another 2 coming up in subsequent months, so please pick them up, and that way Karen will be happy, and I've at least done part of my job. Before we begin proceedings, I'd just like to show my respect and acknowledge the traditional custodians of the land, of the elders past and present on which this event takes place. As suggested, John Darcy can't be here tonight, so I'm going to be your MC for the evening. The Kolling Knowledge is a seminar series which we're putting on primarily for you, the community, to give you better information about different diseases that we're doing research in, teaching, and ultimately also treating as patients. Just one other word of warning, if you could please turn off your mobile phones. So for those of you who are clinicians in the room, please just switch those to silent. I'm sure those patients will wait until afterwards. But our intent within the Kolling, and I might ask Jonathan Morris, who's the Dean of the Northern Clinical School and the Chair of the Kolling, to say a few words in a minute, is really to embed teaching and research within clinical practice. And the clinical practice I'm talking about is basically the treatment of patients who have a variety of health conditions, and ultimately, both from a research and teaching perspective, it's really important for us that be an integral component of that exercise. Jonathan, do you want to say anything about the Kolling itself?
So thank you, David, and good evening. I'd just like to add my welcome to David's. My name is Jonathan Morris, and I'm the director of the Kolling Institute. And I guess here at the Kolling, as David has alluded to, what we want to do is really bring together our researchers and our educators in a united way to address the problems that we face with respect to health in the widest sense. And what we want to do is make that research relevant, and the people who will make it relevant are the community and yourselves, because although we know about the conditions that our researchers are seeking to find answers for, we don't really know about them like those who experience them or have relatives who experience them. So to make our research relevant, we do want to come together with the community. We want to make sure that our research is ensuring that those who we care for in our community have the best healthcare journey if they do interact with our services, and also what we can do to help keep our community well and healthy and therefore outside of our hospitals. So I'm really thrilled that so many have come along this evening. Thank you for that. I'm sure we're in for an educational and really a great evening, and I just also like to acknowledge the man who's on the screen there, who David I'm sure will talk about. Philip was a great loss. He was a great colleague of mine, and we miss him dearly. So thank you.
Thanks, John. Tonight's focus is on osteoporosis, and particularly on Professor Philip Sambrook, who ran the rheumatology department up until a couple of years ago, when unfortunately he passed away. We're pleased, greatly pleased to have Brenda, his wife, here tonight, and I'll ask Len to say a few words in a moment about Philip and the legacy that he's made for us, and what we're really trying to do here tonight to remember that legacy. Tonight also serves the purpose of helping to let you and the community know about osteoporosis as a disease. So later on in the evening we'll hear both from a patient, a clinician, as well as a researcher about various activities that are going on within that space. It is behoved to me to talk to you about, I guess, the various entities here that do work within that space. So obviously there's the metabolic bone unit, which Professor Len March and Professor Rory Clifton-Bly work within. The Institute of Bone and Joint Research and the bone and joint researchers here at the Kolling, who focus on osteoporosis, arthritis, and a number of other musculoskeletal diseases, in addition to us being part of the Kolling, being closely connected to the North Shore Hospital, and really trying to embed our research and our teaching within the hospital, as well as through the greater university and the education that is embodied through Sydney University. Without further ado, what I'd like to do is to acknowledge one more entity, is the bone and joint decade. And I'm pleased I looked in the direction I did right then, because otherwise it would have fallen off my notes. But the bone and joint decade is an initiative which was established in 2000 and was reinitiated in 2010 to really highlight and promote the importance of musculoskeletal disorders of all types throughout the world. And it's an international effort to try and help different organisations collaborate and focus their awareness and increase the importance and awareness of those issues throughout the community. And I'd particularly like to acknowledge the support of Ruth Lillian, who's here tonight, who's helping to run the Bone and Joint Decade from an Australian perspective. So thank you very much to Ruth. So without further ado, I'd like to pass on to Lynn to talk to you about Phil Sambrook. So Lynn, I'll pass off to you.
Thank you, David, and thank you, everyone, for being here tonight to learn about osteoporosis and learn a little bit more and reflect on Phil, who many of you know well and worked with and loved, and also many of you were also his patient. So I'll start with a quote from Philip that, can we see that okay? Yeah. A quote from Philip was, several years ago, where he really said, his passion is to improve patient care and improve for those who suffer from bone and joint disease, and that he really felt we could only do that by constantly pushing those barriers of research. And he lived his whole working life exactly sort of driven by that passion. He embodied that passion. He was our Florence and Cope Professor of Rheumatology at the University of Sydney from 1996 to 2012. He was chairman of the Bone and Joint Research Foundation and the Institute of Bone and Joint Research. In his career, he published more than 350 peer-reviewed research articles about osteoporosis, and in fact, in his he had a 2-year diagnosis from his melanoma, unfortunately, and in that final year when he stepped down a little bit to be working part-time with known metastatic melanoma, he still published another 35 articles or something extraordinary. He had us all still on our toes, still working, come on, we've got to get this one done, we've got to get that one done. He was still pushing right to the end. He was such sort of a brave and inspirational man for all of us. And he was the Foundation Medical Director of Osteoporosis Australia and received an OAM for his incredible services to rheumatology and osteoporosis and bone and joint research. So just along those lines, in terms of, he was an amazing advocate for osteoporosis. So many of you, I'm sure, will have seen him on various Today shows and Sunrise shows and the ABC and 7:30 Report. He was repeatedly advocating for the importance of osteoporosis. He was a main prime mover in getting many of the osteoporosis medications that we have available that I'll tell you about. He was key in lobbying and doing the clinical trials. He did all of the original research on many of the older and new drugs to bring them up to the point that we can make them available to you. And always, as I said, spoke for the benefit of patients was his primary motivation, including down there on the bottom right-hand corner was when that was on the ABC, the 7:30 report. And in that he talked a lot about the osteoporosis medications, and as many of you will be aware from a lot of the media, that some of them have side effects. Some of those side effects can be quite serious and dangerous, but fortunately they're quite rare. And on this particular interview, they misquoted or took some of his what he was saying out of context. Well, it was a due mark of respect to this incredible man that they, and I don't think it's ever happened before or since, that they allowed him back onto the 7:30 report to correct what they, how they had misquoted him. So he was so adamant that the facts should be right, and that the way he had been quoted was potentially upsetting and harming patients, and he wanted to set that fact straight, and they let him do it. So, as I said, never been done before or since. Marvellous man to so many people, connected to so many, very devoted there to Osteoporosis Australia and the peak consumer organisation for osteoporosis. Wonderful mentor to so many people, a number of you in this room, in terms of, he made our careers, he enabled our careers, supervising PhDs, supervising colleagues, and some there, and obviously clearly a lifelong lovely partnership and love with Brenda and his Kangaroo Valley. And the other claim to fame, he won the prettiest baby competition when we organised matched the baby photo to the person now in the department. So there he was, prettiest baby. He wins every competition, and who would have known that pretty baby would go on to reach such great heights? Here he is on your left, climbing Mount Kilimanjaro, and he did that to fundraise for arthritis and osteoporosis research, and then rewarded there not long after his distressing diagnosis, but awarded there with the OAM on the steps of Government House. So I think, we remember him fondly. But he was an inspiration. He really was a man well above all his peers in terms of his contribution and his commitment to research. And because of that, we felt that it would be very fitting, as part of our fundraising, to have a memorial PhD scholarship for bone and joint research, and that's sort of part of where we're headed from tonight. So I'll leave the reflections there, but what we also would like to do, one of the things that his big commitment to research was that he had a bone density machine where we did a lot of our research studies. And after his death, we were very grateful to Brenda, his wife, and the family, that they donated that machine to our research efforts. So we have that machine now in the hospital to continue his dream of pushing those boundaries and doing the best we can for patients and people with osteoporosis. So I'd like to unveil the plaque that we will put outside the bone density room, and ask Brenda to come and unveil that and accept that, and maybe say a few words if you'd like to, Brenda. Yeah. Well, unfortunately, it's not a lovely purple
not
curtain.
No curtain. I can pull the string.
Yeah, you can pull the string. Who's got the champagne?
That'll be nice.
Okay, there you go. So that's that will sit out. Do you want to read it out, or would you like
you can read it out.
That's a trick. Now I've got to get my glasses.
Hiding mine.
Okay. So the plaque says, the Northern Metabolic Bone Centre and Institute of Bone and Joint Research acknowledge the memory and lifelong contribution to osteoporosis research of Professor Philip Sambrook OAM, and wish to thank Mrs. Brenda Sambrook and children Andrew and Catherine for their generosity in donating the bone density machine for our use in osteoporosis research.
Thank you. Philip used to joke often that Lynn and I were very, very similar. I'm not sure if he ever spoke to you, but my speech is almost verbatim on what you have just said.
Do you want that, or you?
I think nobody's that interested. I'll speak loudly. But I did want to say that on behalf of Philip's family, I'm actually very, very delighted that we are able to donate the machine. Didn't quite have a place for it in our lounge room, so it wasn't so much of a hardship. But still, I'm delighted that it can continue to play the vital role that it has for the Institute of Bone and Joint Research in the investigation and assessment of some of the diseases that the clinicians and researchers of the Department of Rheumatology at Royal North Shore undertake. I would also like to, if you indulge me, this is my first public opportunity to say this, but I would wish to offer my personal congratulations to David Hunter on his appointment to the chair as the Florence and Cope Professor of Rheumatology. I know that Philip would have been so very, very pleased and so very, very proud that one of his students succeeded him in that role. I must also make mention of Lynn March, the Liggins Professor of Rheumatology, also appointed this year, in fact not appointed to an existing professorship, but recognised for her dedication by the formation of this chair and the marvellous fact that in its inaugural recipient, not that gender should be an issue for holders of high office, is very much a lady with very few equals. Once again, thank you to all of Philip's colleagues and to his patients who have so generously ensured that his legacy will continue to live on. Thank you.
Thank you very much, Brenda and Lynn, and greatly appreciate your coming along tonight. There is a handout for those of you who want to contribute to Philip's legacy and the PhD Scholarship. Michelle will have papers distributed later to allow you to facilitate contributing to Philip's legacy with regards to that PhD Scholarship. So for any of you who would like to do that, that will be available to you as well. So without further ado, we'll get onto the program for this evening. And what I'd like to do is to let you know that we're going to have a brief conversation with each of the speakers. They'll then make a presentation, and then at the end there'll be plenty of opportunity for you to ask questions. So can I ask Rory, Lynn and Trish to come up and occupy these seats up here? Well, I have to... But what I'd like to do is to provide each of you an opportunity to tell us why you're here. So I'd like to introduce firstly Patricia, who's a patient of one of these fine doctors, I will assume, who's our patient representative tonight to talk about osteoporosis. So Trish, I guess in the first instance, could you please just tell us why you were here? What does osteoporosis mean to you?
Sure. Thank you. Well, thank you for the opportunity to be here. I'm a physiotherapist and very active, busy person. And when I helped, actually several physios in the late 80s, 90s, helped calibrate a new bone density machine in Clinic 1, they needed subjects. And I got the result that I was denser than the average Caucasian American, which I thought was an insult. But I then discovered there were no Australian standards, and it was actually good to be denser than the average Caucasian American. So, and that continued. And then when I was in my early 40s, I had a bone density and I'm becoming osteopenic. And then that's repeated every 2 to 3 years, and I'm getting more and more osteopenic. Until 2009, when I fell and fractured my wrist and I had an osteoporotic fracture. And during this time I'd had a lot of funny autoimmune things, and so fortunately I went along to see Dr. Marsh at the clinic, and to cut a long story short, I discovered that I was a celiac and had been a celiac all my life, but because I didn't like pasta much and I didn't like things, I'd avoided things, but I was celiac. And while I was eating gluten, I wasn't absorbing all the calcium and the vitamin D I'd been taking since 2004 when I started to get osteopenic. So you're taking these things, but you're not absorbing them. So then I was very grateful for that diagnosis, and I've since 2009 been on Actonel, which is now 5 years. And my bone density went up 6% the first time and further the next time, and gradually increasing. And I believe I'm about to go on a drug holiday. so that I don't know how long that'll last for, but I still take my calcium and vitamin D.
Fantastic, Trish. We'll come back to you, and next, I'd like to segue to Professor Lynn March to tell us a little bit about why she's here, and particularly about the clinical presentation you'll give later on. Thanks, Lynn.
Thanks, David. So I'm a rheumatologist and been looking after patients with osteoporosis for quite some time and involved in some of the clinical trials. But I guess one of my passions, and Rory's, we share this one, and I'll talk about it in my talk, but one of the key things that happens as a risk factor, like Trish, most patients don't know they've got osteoporosis until they break their bone. And then we know that once you've had that one fracture, it's a really big risk factor for you having another one. And the other thing we know about from lots of studies is that many patients have had one fracture and don't get onto the right treatment. So we're kind of, we've really been trying to sort of get the right clinic and the right service happening so that once you have had a fracture, we'd have a way to pick you up and get the tests done and hook you up with the right treatment that you need. So I'm going to talk about some of those treatments later, but always remember that once you've had one fracture, you better do something about it.
Thank you. Rory Clifton-Bly, and I'm an endocrinologist. I'm here because Lynn told me, and I do, and I do everything that she tells me to. Even more so now that she's a full professor. But Lynn and I work closely in the area of bone and mineral management, and more importantly, I'm here because 10 years ago, Professor Sambrook encouraged me to get involved in osteoporosis research and clinical care, and in doing so, introduced me to one of the most rapidly advancing areas in modern medicine. The progress of medical care over the last 10 years in bone biology, considerably stimulated by Phil, has been extraordinary. And you'll see a glimpse of that in Lynn's presentation. And I'll also bring some of our own research and particular focus here at the Kolling Institute in my presentation later on today. But I owe a great debt of gratitude to Phil Sambrook. He was a mentor beyond compare, and his ability to inspire young clinicians and researchers is really something that lives on today.
Thanks, Rory. Before we cut to Lynn and Rory to give their presentation, I just want to get a couple more insights from Trish about her experience of the disease. Now, Trish has the fortunate opportunity to work in a plaster room dealing with a lot of fractures. But I'd just like to get your insights from your own experience, what that fracture meant to you and what the disability and the consequences of that were for both your personal and professional life.
Thanks, David. You always expect it to happen to someone else, and I see 20 or 30 to 50 fractures a day, but they're all on other people. And I cross-country ski, I fall over a bit, I come off push bikes, but I hadn't had a fracture, and then I had quite what I thought was a reasonable fall and had a big fractured wrist, but it wasn't just a simple one, it was very deformed, and I was in the country and had to drive myself back to Sydney for 6 hours, and it was my dominant hand. And I think we take for granted the normal things we do, and it's a huge impost in your life, a big problem when you suddenly can't use your dominant hand or you're on crutches. So I see that inconvenience in people every day, and from just being normal functioning adult, they can have huge problems functioning. If you're a mother with 3 children and you've got a cast on your arm, you can't get it wet, or you're on crutches, non-weight bearing for 6 weeks, or you can't drive, you can't get to work, it's a big problem.
And just a few personal insights too on what the diagnosis of celiac has meant to you, and particularly to your health, in addition to how complicated is it to manage your osteoporosis?
It's not. The most complicated thing is remembering to take a tablet on a monthly basis. Just remembering that month and remembering to take things, but that's just a routine you have to get into. The diagnosis for me for celiac disease was fantastic. because there were a lot of questions. Why was I getting these things? Why had I been anemic most of my life? Why had I been getting autoimmune diseases that no one could explain? Why did I have parents in their 90s with fantastic bones and I'm osteoporotic? So I was actually very excited when I got a diagnosis of celiac disease. It's a bit awkward when you go out to places for dinner, but you get used to that, and it's been great for me.
Fantastic. Thanks so much, Trish, Rory and Lynn. What I might get you to do, Rory and Trish, is to take your seat. I'm going to hand off to Professor Lynn March, the Liggins Chair of Rheumatology and Epidemiology, to talk to us about the management of osteoporosis. Thanks, Lynn.
Okay, thank you, David. And here we see a few pickies of what osteoporotic bone looks like and what happens on fracture. And I'll talk a little bit more about this as we go through. But here's a wrist. I don't think it's Trish's wrist, but it is a wrist, and there's a crack through both bones in the wrist there. Here are some vertebrae that should be round about that shape, but they're squashed down, little sort of wedges, hardly anything left of that one there, if you follow the little diagram. And here's a hip where the head of the femur has been cracked right off. So that's kind of what we see on X-ray when someone's had an osteoporotic fracture. So what is osteoporosis? Well, it's all about sort of brittle bones. And here we see on this side normal bone. So normal bone does have some holes in it. It's meant to have some holes in it, and in there you get the bone marrow and all the good things that we need as well. But it's got all these sort of thick trabeculi that hold that bone together and hold us up, and we can jump up and down and all of that, and nothing breaks. Well, not too often. But in osteoporosis, not only do those struts in your bones get thinner, they also drop out and you start to lose them, and the holes get bigger and the struts get thinner, and overall the bone gets more brittle. And that's what's happening there. Why does it happen? I'll come on to some of that. So one of the definitions is exactly that, sort of what do we see on the bone biopsy. And then the other definition that many of you may well have had a bone density scan, this is showing a scan of a hip. So this is your femur, and this region we call the neck of the femur. And the reason why this is quite important here is that if you get a fracture across there, that's the main blood supply, and so this part, the head of the femur, doesn't survive. So that's why when people talk about the neck of the femur, they're not talking up here, they're talking in terms of the bone. But what this will be sort of a typical report, and maybe some of you have seen your report, and they've shown, sometimes it's in colour, sometimes not, but we look at your dot and we compare it to other men and women your age, and we do have age Australian norms to compare to now. If you're up in the green zone, you're doing well. If you're in the yellow zone, you're osteopenic, so you're on the way to osteoporosis. And if you're down in the red zone, you have osteoporosis on this definition. Now, when we talk about T-score, that's just a statistical thing. So it's sort of how well do you compare back to young men and women. So it's a distribution. So not only do we look at where you compare to age, but we say, well, what should your bones be if you were the strongest, fittest, youngest bones, and how far have they declined over time? It doesn't progress that well. I'll talk a little bit more about it in terms of the natural decline and things. So these are the scores that we are guided by the WHO for defining osteoporosis. They're also quite useful for the clinical trials that have been done. So the research has been done using these cut points as well. But the bone density itself is a continuous measure of thickness of the bone. But that's a little bit about the reports. But more than 2 million Australians have osteoporosis as defined by that T-score, less than minus 2.5. And many of them don't know it yet. They haven't had their fracture. But many have had a fracture, and we spend more than $20 million every day on treatments and sequelae related to osteoporotic fractures in Australia. And 1 in every 2 women here in this room and 1 in every 3 men who are over the age of 60 will have an osteoporotic fracture in their lifetime. So it's very, very prevalent. And every 5 or 6 minutes, someone is admitted to an Australian hospital emergency department fronting up with an osteoporosis-related fracture. And just by the nature of our ageing population, perhaps our ageing population being a bit more ambitious with some of their activities even, but that's expected to be at least every 3 to 4 minutes there'll be an osteoporotic fracture in Australia over the next 20 years or less. So 5 years ago there were 50,000 admissions to Australian hospitals for a trauma-related fracture. So it's a really big problem. And what sort of time course does it happen over? So this is now sort of tracking, so that's 50% of women over 50 will experience an osteoporotic fracture. We look here at the in terms of when they happen, and the earliest time sort of that they seem to peak is around 50, 60 in the postmenopausal period, and usually it will be the wrist fracture. Like Trish described to us. Fall onto an outstretched hand, sometimes the simplest of trips up the footpath and onto the outstretched hand, and that's sort of the first sign is in the wrist. In the next decade, it tends to be a little bit more commonly the vertebral fractures, so in the spine. You start to see people get the hunch over as the vertebral bodies collapse down. And in fact, a vertebral fracture is the most common fracture, but in many people it's actually silent. And they don't feel it, or it's a bit of a twinge. But you know what the symptom or what might be happening to you is that you're starting to lose height. And people say, oh, a bit shorter than I used to be, but you might, and if that's one of the signs, that's one of the tests on the How Dense Are You website. If you've lost a few centimetres in height, it could well be because of that vertebrae crashing down. And then in that next decade, from 80 onwards, is the dreaded hip fracture. And the reason most research and emphasis has been on the hip fracture is because of the very significant impact on mortality as well, and I'll just show you some of those data. But before I get there, and I just want to restate that one of the biggest risk factors that we know for having a fracture is having already had one. So again, if you're a postmenopausal woman and you've had one fracture, you've got a 20% chance, 1 in 5 chance that you'll have another one within the next 1 to 2 years. And if you've had more than one fracture, your risk of having another one is even higher. So it's a big signal. And I don't want to be all doom and gloom, but I do want to be a little bit, because just to emphasise the importance of it. In that year following a hip fracture, about at least a third of the people who've come in from being in the community, living independently, will end up in a hostel or a nursing home because they've lost their independence. Less than 20% ever get back to walking the same way that they walked before. Almost all patients who've had a hip fracture will then require a cane or a walking frame. And the scary statistic is that 25% of the people who've had a hip fracture will be dead in the next 12 months. And that is, some people say, okay, they were just a bit older and they were going to die anyway. No, that's not right. They're at least 2 to 3 times more likely to die than someone else their same age. And men get osteoporosis too, and if men have a hip fracture, they're even more likely to die in that next 12 months than if a woman gets a hip fracture. So it's a really important problem to try to stop the hip fracture. And not only the hip fracture, and this is some data from the Dubbo osteoporosis study, and Jackie Centre and John Eisman, who are leading endocrinologists and osteoporosis researchers in Australia, have been looking at a population in Dubbo over many years now, and they've confirmed this hip fracture, these data are just saying that it's nearly 3 times, you're nearly 3 times more likely to die if you've had a hip fracture. But what they showed for the first time, and really made the rest of the world sit up and look at it as well, that not only is it the hip fracture that increases your risks, but even other minor fractures, like a wrist fracture, the vertebral fractures, you're still nearly doubling your risk of dying over that next 5 years. If you've had an osteoporotic fracture. So it's a big signal that we've got to do something about it. And then in men, at all of the fractures, again in men as well, in that next 5 years, they're more likely to die than their other men their age. But, so that's the bit of doom and gloom to say that it's an important message, but there's the good news as well. So this, again, don't worry about all the numbers, just worry about this bottom diamond. So the diamond or the pearl in this particular research graph is showing us that if we treat osteoporosis, so people properly, that not only can we help reduce the risk of that next fracture, now the drugs are getting better and better, but no drug is 100% perfect. What the drugs do is reduce your risk of that next fracture by about 50%, but that's a really good start. But independent of that ability to reduce the risk of the fracture, they can also reduce your risk of dying. And that's some very interesting work. Even in the older age groups who've had a hip fracture, who were looking like more likely to die, if it's treated properly, the osteoporosis is treated and the fractures managed, you can reduce the risk of dying. You can't stop people dying, but you can certainly reduce the risk by treating rather than not treating. So there's some good news. So why do people fracture? It's not just about osteoporosis, but tonight is mainly about osteoporosis. But there are other important aspects. So in the middle, you've got someone who's fractured, but very often, more often than not, someone's had a fall to get the fracture. So there's a whole lot of attention that needs to be paid to strength and balance and hazards and floor rugs and good shoes and things to stop people from falling, and attention to stronger muscles. But your BMD, or your bone mineral density that we were talking about for the osteoporosis, is obviously a key part of it, and that's a lot of what we're talking about today. But it also depends on the shape of your bone and how you fall and how tall you are. There's lots of other factors that impact. So it's not just one thing we have to address when we're trying to sort of fix things up. And bone mineral density is just one way of assessing the bones. It's the easiest way we have with a bone scan. But that microarchitecture that I showed, the pictures of the holy bone, it's very hard to image that apart from, there are some new tools for imaging that aren't widely used yet, but apart from biopsying the bone, which we do in some research studies, but you'll be pleased to know we don't do it as routinely as part of our diagnosis to biopsy the bone. So bone loss is very important. And not only do we, this is looking at that slide again to say, all right, we're looking for how much bone have you lost compared to what we expect the peak bone should be for osteoporosis, but we also look, so that's our T-score. Oh, what happened to my Z-score? Was it? I had another slide. All right. But we also look for whether how you compare to other people your age. And that was the big signal with Trisha's one. That's here she was actually quite young with a very low bone density. You don't mind me sharing that, do you, Trish? In fact, her bone density was like that of a 70-year-old woman instead of, someone, in 50s. But it was quite a bit older than it should have been. But that was the signal to me to look for other causes of osteoporosis, not just, and that was the signal to look for that. But bone loss is really important, and what we know, and this is just another graph to show you that this is now looking at those T-scores. So up here is normal bone, and then this is the T-scores dropping down. But for every drop that we see of a whole one of the T-score, there's a doubling of the risk of fracture. So that is a very strong indicator to us. And not only that, more graphs, sorry, but now we're looking at the bone density and we're looking at the risk of fracture. But for any given bone density, these are all the different bands with age. So a 50-year-old with a bone density here, for lots of other reasons, is not at higher risk as an 80-year-old. So age is a really big factor as well, and I'll come back to a bit about that because there are ways now of identifying, getting closer to what your real risk is to help sort of make the decision of when to start treatment or not treatment. So it's really got to put quite a bit of pieces, a few pieces of the puzzle together. So this is sort of what the pattern of bone loss with age, and we see here that, well, we probably start a little bit higher than 0, but around in the adolescent period is when we reach peak bone mass. So during those growth years, it's really very important. So healthy bones mean lots of physical activity, running, jumping. Kids that run around have stronger bones. Good exposure to vitamin D, good calcium intake in the diet, good healthy nutritious diet, and people get stronger bones. So quite a lot of the emphasis is on healthy bones and getting optimising that peak bone mass, because it's very, very natural that we, with time, and particularly around 50 for the menopause, but the bone density in women certainly drops off. And so that happens in everyone as soon as the estrogen supply is gone. So you can imagine that if you only ever get to a peak bone mass around here, you're still going to go down this way, and so achieving a peak bone mass is important at a population level. And men will lose bone, it just takes a little bit longer depending on different hormones. Okay. Oh, that was my Z-score. There we go. So there's lots of different conditions that can be associated with osteoporosis. So any of the chronic inflammatory conditions, celiac disease like we heard from Trish, rheumatoid arthritis, chronic inflammatory conditions, overactive and underactive thyroids, overactive parathyroids, and Rory will talk a little bit more about that. People who are transplants are on lots of steroids, people who have other conditions who take cortisone. There are a number of other important drugs as well, people who are on big doses of anticonvulsants like epilepsy drugs, some of the anti-ulcer drugs. There are a number of different medications, and now a lot of the treatments related to breast cancer and prostate cancer, in their efforts to switch off the hormones that feed the cancer, they also switch off the hormones that we need for the bones. So many of the things, as we treat people better, one of the side effects of the treatment is the impact on osteoporosis. So there's a lot still we're learning about that. And one of the things that we can do for individual patients is that if you have your bone density, there are a number of other risk factors. So I've said age is important, your bone density is important, whether you've had another fracture is very important, whether you're a faller also gives us a clue as to whether you'll be at risk. So there's a number of different factors that can be put into an algorithm to say, or we don't know exactly that you're going to have a fracture, but we can predict and say, all right, with all of your circumstances and your family history, or your mother or your grandmother had a hip fracture, we can factor that in and say, well, in the next 5 years, you've got about a 10% chance of having a fracture, or you've got, a 50% chance of having a fracture, and then that helps you and us make a decision as to when to start treatment. Because although we've got these wonderful treatments, they're not all 100% free of side effects. There's always some side effects. So you've got to get that balance of when is it the right thing to do for you, the benefits for you outweigh the risks of small risks of side effects. And one of the ways you can decide whether you're at risk is looking at how dense are you, and that's an initiative that the Osteoporosis Australia has. So if they've got a whole lot of material on their website at osteoporosis.org.au. You can do that little bone density test to see if you probably should have a bone density or not. There's a whole lot of other material around. Roy will talk about the calcium and a whole lot of other material about that. kind of spoken about a number of things, and perhaps some of these can come up in our discussion time as to things that you need to do as well. Stop smoking, don't drink too much, make sure you've got plenty of exercise. Particularly, we learnt you've got to jump up and down a lot more. Skipping and jumping, there's slight impact, and people think, oh, I can't jump, but yes, you can. Maybe we can have a jump off later. But just that slight impact will help the bones. 50 little jumps a day, you know, that is enough to be an impact to sort of help the bone density. So those sorts of things are important. But there are a range of drugs. I'm not going to go into all the different drugs, but just to say that we do have them. Rory will talk about calcium and vitamin D. We talk about drugs that if you do nothing, your bone density goes down here. If you take the range of what we call anti-catabolic drugs that stop the bone breakdown, you end up about here. We're now looking at a range of drugs that actually help the bone build up as well, anabolic drugs, and your bone density is going to go up here. All of these drugs can, though, reduce your risk of your neck fracture by about 50%. I probably better not talk for too much longer, as I say. I don't want to go into it, but there are a range of different drugs available, and they all work. And I'll just show you some of the biopsy data to show that not only do they reduce the fracture, but some of this sort of moth-eaten holy bone can thicken up with these drugs, so that's strengthening up internally as well as sort of giving more mineralisation. And I'll just show a few picky slides, cartoons really, to just show you how complex the area is becoming and why the research is so important. A little bit on that. In terms of the different cells, the couple of key cells that we have in their bone is the osteoclast that breaks down the bone and the osteoblast that builds the bone back up. And it's happening all the time in all of us. Constant bone remodelling. At every age, our bone is constantly remodelling. But what happens in osteoporosis is that this guy takes over. The clast is doing a lot more than the blast. So many of our drugs now are targeting at trying to slow down the clast, but we're also looking at a whole lot of new lot to try and build up the blast. These come from the bone marrow. But there's also the cells that sit within the bone, the osteocyte. Now, this is getting even more complex, and every time we go to another meeting, someone's found another little receptor or another little marker getting us closer to a drug, hopefully, that will block the right bit and not cause side effects or not cause some adverse events. So this is really just to show you sort of multiple little molecules now, rank and rank L, they're all little proteins that are either on the surface of cells or internalised in the cells. Many of them need to hook up together to be active. Many of them, depending, can switch one way or the other. Sometimes they'll be switching on the clast and breaking down the bone, and then just with a slight tip in the numbers, they can tip the other way to be blast. So it's really a very complex area trying to identify which are going to be our best markers to target to develop drugs. And there's lots of activity, some interesting new drugs that will be trialling here or are currently trialling here. And one of the things that you might like to do is put your name down for some contributing to our clinical trials as well. So those of you who are interested in that, and I hope we have been collecting names, and many of you in fact have already contributed to a number of our research projects and trials, so that's great. So here's some new ones that are coming along that very strongly build bones up and are working in a different way, and hopefully sort of a slightly different side effect profile. So who should have treatment? If you've had one fracture and your bones are osteoporotic or osteopenic, you probably should be on treatment, or at least discuss it. If you're 70 or over and your bones are osteoporotic, even if you haven't had a fracture, you should seriously think about discussing treatment. If you're on long-term prednisone or cortisone, more than 7.5 milligrams for other conditions, and your bones are osteopenic, even if you haven't had a fracture, you should think about having some treatment. And then there's some other parameters there that we might. So there's lots of questions we haven't answered. We don't know what the best drug is. We don't know how to cure osteoporosis. We don't know really how to prevent it. We don't necessarily know how long to treat. We can talk about that a bit more. We don't know how much calcium. We don't know how much vitamin. We've got a bit of an idea, but Rory will tell you more about that. But there's a lot that we still need to know the answers for. So I will finish with that and hand over to Rory. Thank you.
Thanks, Lynn. That was awesome. So I'm going to talk about calcium and vitamin D. And I'll start with calcium, which is the essential ingredient of bone. And when we measure bone density, we're measuring the calcium content in the bone. And 99% of our body's calcium is locked up in the skeleton. It's the bone bank. It's where our calcium is stored. And the calcium in the bone gives the skeleton its strength. But it so happens that calcium is also really important for every other cell in the body as well. It acts as a signal relay in our brain cells, in our heart cells, in the liver cells, and the muscle cells. It helps us think, our heart to pump, our muscles to move. So we need a mechanism for the calcium to be in the bloodstream, to act in this very important signalling relay, but also to be able to be stored in the bone so that the bone remains strong. So how is the calcium distribution regulated? Well, like everything else in the body, calcium distribution is regulated by hormones. And the two most important hormones that regulate calcium are parathyroid hormone and vitamin D. Now, vitamin D, shown here on the left, acts to allow the intestine to absorb calcium into the bloodstream. Vitamin D also helps the skeleton to trap calcium, and we'll talk about that more towards the end of my talk. PTH, on the other hand, parathyroid hormone, regulates how calcium is eliminated via the kidney, and also has some action on the skeleton as well. So what is parathyroid hormone? It's a hormone that comes from some glands in the neck called the parathyroid glands. And so, sorry, this is my artistry. It's not very good. I'm a boy with limited artistic ability. This is a chin, and this is the neck. And that's the thyroid gland. And anyway, so that's the thyroid. But the things in the yellow are 4 little glands that are geographically the neighbours of the thyroid gland. But like most neighbours in other circumstances, parathyroid has absolutely nothing else to do with the thyroid gland. So please don't be confused. Parathyroid glands are their own unique gland, and their function is to secrete parathyroid hormone. And a hormone, like any other hormone, secretes in the bloodstream and acts at some other organ, in this case on the kidney and the bone. One of Phil Sambrook's many contributions to research in this area occurred almost 10 years ago, when in a study that he was doing with Lynn March, he recognised that parathyroid hormone itself was the Goldilocks hormone. You needed it to be just right. Too much was a bad thing. Too much PTH led to premature death in this older population of individuals that Phil and Lynn were studying. And probably the adverse effects of too much PTH occur through the accumulation of calcium, not in the skeleton, but in the vascular system, in the blood vessels and in the heart. Now, excess parathyroid hormone occurs in one of 2 forms. Phil was concentrating on the secondary form, which we think is probably related to calcium malabsorption as we get older. That's called secondary hyperparathyroidism. Primary hyperparathyroidism is a condition of a tumour developing in one or more of the 4 parathyroid glands. So here, again, my artistry is somewhat limited, but we see a thickened parathyroid gland, which is a tumour in the parathyroid gland producing too much PTH. And in a study that has been going on at North Shore, conducted by my forebear, Philip Clifton Bly, and the study has gone on for more than 30 years, looking at patients with primary hyperparathyroidism, shows exactly what Phil Sambrook discovered, and that is that too much PTH is not a good thing. It leads to premature death. the death rate was, for people with hyperparathyroidism compared to the general population is highly significant. And on average, you lose about 7.5 years of your life if you have hyperparathyroidism. So what do you do if you've got hyperparathyroidism? Well, fortunately at North Shore, we've got the 3 best parathyroid surgeons in Australia working, and that's not hyperbole. They've got the highest volume unit. They do more operations in Australia than any other parathyroid centre. That's Lee Delbridge, Professor Stan Sidhu and Professor Mark Siwak. This is just a graph showing the number of operations they're doing, separated by decades. In the decade leading up to 2002, they did more than 1,300 operations, and in the last decade they've doubled that, and now doing almost 1 parathyroid operation for every day they're allowed to in the operating theatres, when the operating theatres aren't being closed down by the administration. But anyway, you can see the distribution of age, and most hyperparathyroidism does occur. It's more common in women, and it's more common after the age of menopause. And I'll come back to this younger group in a few slides' time. But very importantly, not only are they the best parathyroid surgeons in Australia, but if you go to see one of these 3 surgeons, you're more than 98% likely to be cured of your condition. And why is that important? Well, hyperparathyroidism causes a lot of symptoms. It can cause muscle aches and pains, it causes kidney stones, but it also causes osteoporosis. 1 in 30 women with osteoporosis will have hyperparathyroidism, often undiagnosed until their osteoporosis has been investigated properly. But once the parathyroid tumour is taken out, once the excess PTH is reversed, the bones restore their normal strength. This is a very famous study done in New York by people called Bill Ezekian and Shoni Silverberg, showing that at any of the skeletal sites that are measured, lumbar spine, femoral neck, or the forearm, following a curative procedure to remove a parathyroid tumour, the bone strength improves very significantly. This is as much or better than any of the other drugs that we're using for osteoporosis today. Conversely, if you don't have treatment, inevitably the bone strength will decrease with time. So timely diagnosis and treatment of this condition is very important. Now, my own specific research interest in this area is focusing on the younger group of women and men with hyperparathyroidism because it's more likely to be inherited when it's diagnosed at age of 50 years or younger. So although inherited hyperparathyroidism is very uncommon for the majority of people with hyperparathyroidism aged older than 50, up to 1 in 6 can have an undiagnosed heritable problem of their parathyroid gland. And we know a lot about the genes that are involved in predisposing to hyperparathyroidism in this younger age group. I won't go into the details, but the reason why genetics is so important is not a mystery. Genetics is very important, and you can't go to a medical talk these days without getting some slug of genetics. And it's for 2 reasons. Firstly, knowing that you've got a family member with a genetic condition like hyperparathyroidism enables timely diagnosis in other members of the family. So here we have one particular genetic condition. You don't need to know the particular gene involved, but here we have one individual who was actually diagnosed with parathyroid cancer, aged about 60. But his condition was associated with a genetic mutation, and it allowed the timely diagnosis of parathyroid disease in 2 other family members and curative surgery before the cancer had developed. The other reason why genetics is so important is that understanding the genetics of a condition and the heritable factors that lead to a condition allow you to find new drug targets. So understanding that the calcium sensing receptor causes some proportion of hereditary hyperparathyroidism identifies that calcium sensing receptor as a drug target. And shown here on this slide, on the left are a number of mutations that I've discovered in the calcium sensing receptor in this gene, and it tells me, yep, this receptor is important to study for calcium metabolism. And over here on the right is a drug that is an early version of a PTH modulating drug called Sensipar. The renal kidney doctors use this a lot to control PTH levels in people on dialysis. And you can see the drug works beautifully. In the purple line, this is calcium on the y-axis. People on this drug, the calcium is restored into the normal range very quickly. So genetics is important. It helps us not only care for patients and their family members, but it helps us find new targets for treating. Another thing I'd like to highlight about advances at the Kolling Institute are our ability to look at very complex genetics in a much more rapid fashion with new technology. Previously, if you went to have a genetics test, the test itself was very laborious. It could take more than 12 months to sequence a gene, particularly in the very large genes. And if you were looking at more than one gene, as is the case for hyperparathyroidism, it's going to take forever. But there have been some advances in medicine in the last really 2 or 3 years, where our ability to sequence large numbers of genes, so a very high volume of genetic material, you can do it within 24 hours. And this is part of the advance of modern medicine, which Phil Sambrook recognised very early on and said, this is part of the excitement of working in medicine these days. You can do things in so much more effective and powerful ways using new technology. And so using machines like this, rapid genetic diagnosis, which obviously identifies people to earlier treatment. So I'll spend a few minutes now talking about vitamin D. It's the sunshine vitamin. Here we see Little Miss Sunshine, flagrantly plagiarised from the internet. Vitamin D also links to PTH. This is a classic. It's one of the best, most reliable observations in medicine, that the lower your vitamin D is, the higher your PTH is. This is just one study, but it's been replicated over and over again. So with vitamin D deficiency, your PTH goes up. And as I said, PTH is the Goldilocks hormone. It needs to be just right. Too little is not good, and too much is certainly not good, as I've discussed before. Too much leads to premature death. So what are the stages of vitamin D deficiency? If you're mildly vitamin D deficient, you've got a slightly increased PTH, and over time you'll lose bone, but slowly. If you're moderately vitamin D deficient, we're all sitting inside. I really would encourage these lecture series to be held outside, particularly over the summer months. But if you're moderately vitamin D deficient, which will be 2/3 of this room, the PTH goes up and that accelerates bone loss. And if you become severely vitamin D deficient, in adults that causes a condition called osteomalacia or soft bone, and in children it causes rickets. Now, here we have on the left-hand part of this slide an illustration of how mild or moderate vitamin D deficiency causes bone loss. This is hip bone density on the y-axis, and as the vitamin D levels go down, you can see that the hip bone density goes down as well. And this is comparatively mild vitamin D deficiency. But then if we look at more moderate and severe vitamin D deficiency over here on the right, this is a bone biopsy that's been stained with fancy colours. The good bits are blue. So the red bits are all the bone that doesn't have any calcium in it. And when people have severe vitamin D deficiency, their bones don't mineralise. And their bones become soft, brittle, they break easily, and they cause a lot of pain. So vitamin D, very important for bone structure. This slide, too old for anybody in this room to remember that in the 1920s, there was, in the children of the Depression era, there was a significant amount of rickets. And here we have a child with bent legs, characteristic of rickets. You can maybe also just make out the so-called rickety rosary of the rib cage. So very severe rickets, but in the 1920s it was appreciated that it was sunlight, it was UV light that allowed for the active conversion of vitamin D in the skin. And so this child was actually being treated with a UV lamp to activate vitamin D and heal the rickets. And here on the right-hand panel we can see just how effective sunlight is. So here we have an X-ray of this child's wrist, with, not to go through all the details, but very important bones here in the carpal region are missing because they don't have any calcium in them, and after treatment you're getting calcium back into the skeleton. So sunshine's very important. Another study which I was very pleased to do with Phil Sambrook was to look at some of the genetics associated with vitamin D metabolism, and showing that one particular genetic variant, which is important in triggering active vitamin D, was itself a risk of fracture. So people with one of the genetic variants of this enzyme were 34% more likely to have a fracture compared to people having the more protective variant. And this was on the basis of Phil and Lynn's FREE study, which was conducted in people living in hostel care. So what are the high-risk groups for vitamin D deficiency? Well, they're the elderly, particularly living in nursing homes, or if you have a medical condition that requires you to avoid sunlight, in particular, predisposition to skin cancer. People with darker skin, the skin pigment does inhibit the activation of vitamin D, so skin pigment itself is a risk factor for developing vitamin D deficiency. And malabsorptive conditions such as celiac disease, also a very important risk of vitamin D deficiency. This is a slide just showing you how effective the Slip Slap Slap campaign is going, which is why vitamin D deficiency is alive and well in Australia. And if you're using sunscreen appropriately, in my view, you certainly need to be mindful that you may not be getting enough vitamin D from the sunlight. If the UV light doesn't get to the skin layer, it doesn't make vitamin D. So that's not to say don't use sunscreen, it's just to be aware that that sun avoidance or a liberal use of sunscreen does render you at risk of vitamin D deficiency. Fortunately, you're allowed to take it as a tablet, widely available, very cheap, in a number of various formulations and completely palatable, so not difficult to take at all. How much sun do we need if we're getting our vitamin D from sun? Well, in Sydney in summer, it only takes about 7 minutes to expose your face and your forearms to sunlight to generate enough vitamin D, and that's at 10 o'clock or 2 o'clock, avoiding the midday sun. In winter, the time required per day to generate adequate vitamin D is closer to 27 minutes in Sydney. Now, you'll notice that vitamin D is not only dependent on the season, it's also dependent on where you live, and the further away from the equator you go, the more at risk of developing vitamin D deficiency you are. So for those of us lucky to visit or live in Hobart, fine in summer, but in winter you're much higher risk of vitamin D deficiency. And that's led the Tasmanians to have fairly wide-ranging recommendations on liberalising the school children's exposure to sunlight in Tasmania, where it's more restricted in the more northerly states of Australia. All right. So I'm going to finish with some general recommendations for calcium and vitamin D from Osteoporosis Australia. And in doing so, Osteoporosis Australia benefited enormously from Phil Sambrook's guidance, and it's a passion that he's transmitted to both Lynn and I, who are now serving on the Medical Advisory Board of Osteoporosis Australia. So how much calcium do you need in your diet to sustain healthy bones? Well, for normal healthy adults, you need 1 gram a day. From your diet. And at the Osteoporosis Australia website, osteoporosis.org.au, you can get a calcium calculator that will tell you how much calcium is in food per serving. And it gives you a general idea of whether you're getting enough calcium. For women over the age of 50, so in the menopausal years, or men over the age of 70, you need more calcium because the body doesn't absorb it as well. As we get older, and particularly in women after the menopause, calcium absorption goes down markedly from the gut due to various hormonal influences. If you've got osteoporosis, you also need a bit more calcium to keep your bones healthy. But the good news is, even a diet that has minimal amounts of dairy, there's still some calcium intake in the diet, and general recommendations are these days that calcium is much better got from dietary sources. If you can't drink milk, if you can't eat yogurt, then you might need a calcium supplement, and probably 600 milligrams of calcium carbonate supplemented with vitamin D is the best way to go. There are some other calcium preparations which might be suitable for particular medical conditions. What about vitamin D? Well, we all need a vitamin D level that's over 50 nanomoles per litre. I can tell you without doing any measurements that 2/3 of people in this room will have a vitamin D less than 50 nanomoles per litre. If you think you're at risk of vitamin D deficiency, see your GP and have a test. And if your level is low, you either need to take extra sunlight, being very careful about the skin cancer risk, or you need to be on a vitamin D supplement. The vitamin D supplements are very easy to take. Vitamin D deficiency is particularly important for people who spend a lot of time indoors, or who have darker skin, or who otherwise have social or medical conditions that prevent them from seeing the sun. As with everything, there are far more questions than there are answers, but I hope in Lynn and my presentations today we've offered you a glimpse into our passion for osteoporosis and for the bones, And that passion is really being provided by Phil Sambrook, in whose memory we dedicate tonight's education session. Thanks.